Great. So ACMHAI has a YouTube page, and we will post this webinar to our YouTube page and also share it out with our membership and for those that are interested in viewing at a later date. Again, this is one of our professional development webinar series, and this came about through our Children's Behavioral Health Committee in honor of Children's Mental Health Acceptance Awareness Week. So thank you all for joining us, and thank our speakers so much for participating. At the end of the presentation, we'll have an opportunity for questions and answers, and we can determine whether a chat box or a hello, and we can call on you to ask your question. So with that, I will go ahead and introduce our today's speakers, and then I will hand it over to them. And I share my screen with the presentation. So first speaker, Amy Starren, is a clinical social worker with over 35 years of experience in children's mental health. She's held leadership positions in community mental health, inpatient psychiatry, government, university research, teaching, and nonprofit organizations. She's currently the Senior Program Officer for Mental Health at the Illinois Children's Healthcare Foundation. We also have Divya Mohan. She's a public health and communication specialist with more than 18 years of experience working in the philanthropic, nonprofit, and public sectors. She is the Health and Strong Families Program Officer for Polk Brothers Foundation. Dr. Sonia Leathers is a professor at the University of Illinois at Chicago, Jane Addams College of Social Work. She has post-MSW experience, including direct practice with children and adolescents placed in foster care and behavioral parent training. And last but not least, Michelle Churchy-Mims is the Vice President of Child and Adolescent Policy and Practice with the Community Behavioral Healthcare Association of Illinois. She's provided direct services, program development, and implementation of mental health programs with youth and families in Illinois for over 30 years. So again, thank you so much to our speakers for joining us today. And I will hand it over. Would you like me to go ahead and pull up the PowerPoint presentation?
Yeah, Jody, if you would do that, that would be great.
Absolutely. Just one sec. Okay.
Okay, thank you, Jody and Debbie, for inviting us to come talk with you guys this morning. So everybody's fairly aware of, I'm sure that you're hearing the same things that we are in terms of the mental health crisis. Pretty much every group, every national group that has anything to do with providing child services has declared the children's mental health need at the level of a crisis. So what we're going to talk about this morning really, or this afternoon, I guess, really is to give some examples of things that is happening in Illinois related to addressing the workforce issue. Next. So I put this slide up and I said the scope of the crisis, and then I thought, well, there's really no need to say very much about this because everybody's very clear on, I think, the nature of the crisis related to children's mental health need. Next. I did want to spend, really acknowledge that the need is increased, but the workforce has really decreased. And the Community Behavioral Healthcare Association in Illinois, who Michelle Churchy-Mims works with, I think has done the latest assessment of the gap in terms of what Illinois needs related to the mental health workforce. Next. So CBA surveyed their members in January of this year, so just a handful of months ago, and they have 93 members that are mental health serving agencies that are part of their association. And half of those members provide services to children. So overall in Illinois, there's somewhere in the ballpark of about 250 organizations that provide mental health services at some level. So CBA represents just under half of them. And within those 93 agencies, there were almost 6,000 vacant clinical staff positions open. So it's important to think about the concept that they're clinical positions. These are not administrative. positions, but these are the people who are actually doing the work with people with mental health concerns. And of those organizations, there were vacancy levels between 4 and 104 positions per agency. So the agencies out there are hurting. The wait lists are long. So there's over 9,000 people on wait lists for mental health and substance use services. And even if we think about the fact that many of these are adults that are parenting children who are in need of mental health care themselves. And that the wait lists range from about 20 to 300 people on these waiting lists per agencies. One of the things that we're hearing from our grantees, and certainly that SEBA also highlighted, is that 40% of these organizations have had to close admissions because they just haven't had the staff to take care of them, take care of the clients the way they would like to. Next. So what do we attribute the attrition in staff to? The burden of Medicaid documentation is something that we've heard a lot about. The salaries are very low. A lot of people are leaving the field and going into other professions that are not as difficult emotionally and physically, and that also pay much better. We're also hearing that a lot of the staff are not feeling like they're really well prepared to meet the higher acuity that needs are presenting with. Supervisors are noting that interns and new graduates from master's programs are less prepared to meet the needs of families, and that the agencies themselves are feeling a burden of providing more supervision and in training. Next. So it's interesting to think about what has happened. So many of us who are older clinicians were trained in community mental health agencies back in the 80s and 90s and early 2000s, when there was a really very robust training system that was housed within the community mental health agencies. So these agencies trained multidisciplinary mental health clinicians, social work, counseling, psychology, psychiatry, nursing, marriage and family therapy. And they could do that within the structure of having grant funding. In 2009, when the state began to move to a fee-for-service model, agencies only got paid for what they produced in terms of billable hours. And that capacity of the system of these institutions to really provide robust supervision and training for interns and for early career staff really has eroded significantly. We also know that clinicians really value supervision and really say that it has a very significant impact on the quality of the care that they're able to provide for clients. Next. So we heard from a number of agency leaders. This is a quote from Bernie May at Family Service Center of Greater Elgin, just related to what has happened over the last 10 to 15 years with the erosion of this supervision and training system. And so at this point in time, there's essentially, we're looking now at the next generation of clinicians who were kind of early career folks in 2009 to 2012 and beyond, who are now in positions of becoming supervisors in these organizations and really just not feeling well prepared to do the work. Next. So there are a couple of examples we're going to talk about. Some are funded through philanthropy and some are government type efforts. And I'm going to talk about the paraprofessional workforce is a potential solution to extending the mental health workforce. Next. So this is a group that was brought together under the auspices of the NB lawsuit settlement to really look at the issue of workforce. And this is a list of participants. So we had a really robust group of representation from all over the state of Illinois and from many different child serving systems. Next. So the goal of the workforce committee was to really look at ways of enhancing, expanding, and improving the workforce of the non-licensed mental health workers to be more effective in working with children and families in particular. Next. So again, many agencies providing child services are really having a very hard time even coming up with one licensed clinician, which is what Medicaid requires, is the credential to sign off on treatment plans. So the need to really extend who can actually intervene with children and families is really very clear. And as the NB lawsuit and some of the other transformation efforts look at increasing the need for clinicians at multiple levels, it just becomes more clear that the paraprofessional workforce can really be a potentially very powerful assistant to the licensed folks. Next. So the idea is that these are paraprofessionals under the Medicaid billing regulations. They're RSA rehabilitative service associate level. And depending how much experience they have, they could also potentially bill Medicaid as a mental health professional. So these positions exist. The effort is really to try to understand how to help them be more effective in working with children and families. Next. So this group came up with recommendations for the kinds of skills that they felt like paraprofessionals needed in order to most effectively intervene with children and families. So there are many evidence-based interventions for children, many evidence-based interventions for caregivers. And the assessment of this group was that the paraprofessional level under the quality supervision and oversight of a licensed mental health clinician is in a position to implement roughly half of them. So we did a lot of work kind of enumerating what these competencies needed to look like and thinking about how they could get those skills. We felt like they needed to have skills related to linkage and navigation, so more care coordination, case management kind of skills. A solid understanding about professional responsibilities related to providing children's mental health services, so things like boundaries and confidentiality. And then also a good understanding of basic child and family foundations, child and family development, and ways to support the relationships within the entire family and not just focus on the child. Next. So this is an example of the core skills that this group put together and really looked at what were the core skills, looked at the extent to which the paraprofessional needed to be aware of the practice, or whether they, to the extent that they needed to have awareness, knowledge, and could really perform the evidence-based interventions related to each of these. There's a electronic evidence-based resource system. I don't know a better way to describe that. I'm sure there is one called PracticeWise that all of the community mental health agencies that contract with DMH, and I think also now the behavioral health centers, have access to, that I think has been underutilized, but it has training videos and practitioner guides that really walk step by step through how to perform these basic skills. So there's already an existing infrastructure for doing training on pretty much all of these interventions that were identified as being able to be performed by a paraprofessional level staff. Next. So this is, as I was just mentioning, practice-wise, if anybody wants more information on that, I'm happy to help folks get linked to it. Essentially, practice-wise is a remarkable resource where they have looked at all of the manualized evidence-based interventions and pulled out the specific interventions. So for example, exposure therapy is one of the primary interventions to help kids deal with anxiety. And practice-wise, I think at this point has over 1,200 manualized interventions that they've really looked at and pulled out specific practices in them. And so of these many manualized models, pretty much all of them who are trying to address anxiety in children have identified exposure as an important component to it. And so practice-wise, we'll sort out, you can do searches around specific problems that children have. You can look at different populations, and it will tell the clinician what the most effective interventions are for that level of problem in that particular child and demographic. So it's a great resource, and it's one of the resources that the NB work group really thinks is important in terms of helping to prepare paraprofessionals to do this work. Next. So also believe that there are multiple ways that paraprofessionals could be appropriately trained. So kind of the traditional model of in-agency training is something that will have to be part of the training for all sorts of reasons, not the least of which is compliance with Medicaid and documentation requirements. The practice-wise system, again, that we just talked about. And then there is the potential for institutions of higher learning and community colleges to really pick up helping prepare RSA level paraprofessional staff for this kind of work. It's something that the Division of Mental Health has rolled out recently related to the CRSS adult peer intervention level staff. And it's kind of exciting to see that happen in the adult side. It would be awesome if DMH also supported something like that on the child side related to paraprofessionals. Next. Okay, I'm going to turn it over to my colleague, Divya Mohan from the Polk Brothers Foundations, who's going to talk a little bit about some on-the-ground experiences that they're hearing from their grantees.
Yeah, hi everyone. Thanks again for having us, Jody and Amy, for convening. It has been very consistent with what Amy said with our grantees. The Polk Brothers Foundation funds around 400 agencies each year across 13 different program areas. I cover our health and our strong families portfolio. Strong families includes domestic violence as well as youth development. But what I will say is across every single one of our program areas, I am hearing about workforce issues. This is around homelessness. This is in education, all of these, of course, which has a direct impact on children and adolescents who are experiencing trauma. And so the intersectionality here around both the workforce and the trauma is impossible to ignore. I will say that all of our mental health grantees have openings, have struggles to work with Chicago public schools. We only fund in the Chicago area. And so our school-based portfolio has been frustrated with challenges there as well. Our youth development groups consistently were telling us that they just didn't feel equipped. Their staff didn't feel equipped to meet the needs, the ever increasing mental health needs of their young people. And that was pre-pandemic. So, obviously through the last few years, those needs have increased. One specific example I thought was really exciting is that the Girl Scouts their troop leaders, they were funding, they were paying some troop leaders through one of their community outreach programs, but they were part-time jobs and the retention was very, very poor. And they were realizing that people didn't feel equipped to do this job and they weren't being incentivized properly to do it either. They partnered with the Center for Childhood Resilience at Lurie to develop a curriculum for youth development practitioners to become trauma informed. And Girl Scouts then revamped that whole program to make sure that they were hiring enough staff, but paying them a living wage, and then also equipping them to meet the needs of the girls that they were serving. And I think that, just really relates to the paraprofessionals work that Amy has been doing. There are so many people in this space who can be considered an asset in a child's life. And how can we all work together across the varying levels of need to, address that? Does it always take a psychiatrist or a social worker? Can a troop leader have a really profound impact on a young person's life? So that being said, I hope that what that does is create a pipeline to, a mental health profession, and folks from community who do those kinds of jobs will actually start diversifying that workforce too, which I know you'll hear more about soon. But I hope that these conversations and kind of the increased need in mental health services will really spur more of these conversations to think about how we can level the playing field. A lot of the times it's the public sector and the school district that is competing for jobs from community-based agencies and providing mental health services. So how can we all work together to build this pipeline and start early?
Thank you, Divya. We're going to turn it over now to Dr. Leathers, who's going to talk about a couple examples, one funded through Philanthropy and one that really is, I think, just really very exciting, and that is funded by government, and really the onus for it was really public policy related. So Dr. Leathers?
Thank you, Amy. I really appreciate that introduction. And thank you all for being here. Next slide. So I'm just going to talk very briefly about a behavioral health care training program for social workers that we've had at UIC for a bit of time, and then also the Enhancing Diversity program, which we're really excited about. This is a program that we're hoping will help address some of the difficulties that we see in child mental health with lack of diversity. And we'll talk a little bit about challenges to effective training and the importance of placement settings. We actually did not plan for all of these presentations to fit together so nicely, but you'll see that we have a really pretty consistent theme here. So some of the stuff that I'll be talking about, I'm going to cut short because you'll see that Michelle actually is going to be talking about some solutions to some of the challenges. And I will then spend a little bit of time also talking about the Behavioral Health Workforce Education Center, which is just getting started in Illinois. Next slide. So the Integrated Behavioral Health Training Program, this was funded now since 2016 by the Health Resources and Services Administration, which has been having recently a fair amount of investment in behavioral health care workforce development, which is wonderful because we've seen more and more schools in Illinois taking advantage of this, which provides the opportunity to give students who are social work or could be paraprofessional level or other disciplines more advanced training in how to support the behavioral health workforce as they are learning, currently in graduate school and learning about, or whatever training program they're in, learning about how to actually address behavioral health needs. So our current 4-year grant focuses on child through transition age youth, and we provide training in 2 tracks. And just want to recognize Catherine Melka-Keffer, who is somebody who is really invaluable to this program because she provides the training one of those tracks and does a lot of the liaisoning with the agencies, which is so important for the success of this program. With 29 students a year, they're provided with a stipend, which is super important because it helps them free up some of their time so they're able to do more intensive treatment. They're able to do more intensive training in their 2nd year of their program, which includes a summer workshop, a seminar series that goes throughout the year, and then coursework in child and adolescent mental health. And then they also are in a mental health or school specialization where they get additional kind of the traditional coursework also. Next slide. So our program structure really is a bit different than the typical classroom-based training that they're involved in, and that we really focus on skills training. So rather than reading about theory, reading about kind of background of interventions, they read a lot of manuals, and we try to really support them in learning those skills about how to actually use these more structured evidence-informed interventions, understanding that they often have to be flexible, that we often have caseloads of children, family, and youth that have pretty complex needs, and you can't just kind of march through a manual and expect it to work. Often you will just have people fall off because they may have more complex types of needs that need to be addressed more flexibly. If you don't address those more immediate needs kind of up front, people are not going to find this meaningful enough to sustain them. So we spend a lot of time learning those interventions, but also learning how to be flexible and to pivot to try to address those needs that are kind of presenting right there, whether it's safety or it's more basic kind of needs. So we found that learning these interventions before they begin their actual placements where they're going to be able to practice and use them is super important, because what people start to do, even in that first year placement, if you get started doing a lot of supportive kind of counseling, a lot of play with children that's fairly unstructured, it's kind of hard then to shift, course and to start doing something that's more of a structured kind of thing where you're actually looking at, particular sorts of content and trying to work through content with parents and with children. And particularly, I found if you start off working with a child, sort of initiate treatment with a child or an adolescent, and then you realize, I've got behavior problems, and I'm hearing that I should be really working with a parent instead, or doing more of a family focused type intervention, it's super hard to make that pivot, right? Because everybody has a routine where they're all ready for the child to kind of be dropped off. Maybe the parent gets a little break in the waiting room, maybe they go grab some coffee. So getting people oriented towards a family-based type of practice is one of the things that I find is really super important with that early track that I teach in. So we work with parents then to address behavior problems, ADHD, and then we also are supporting people in learning anxiety and depression types of interventions, and trauma interventions also they're introduced to. So we do use the practice-wise. We use some of those modules. I found that what's real important though is that they get more of a deep kind of dive and more understanding of kind of, because otherwise practice-wise can lend itself to kind of doing handout therapy, right? Where they take a nice little, kind of sheet that gives you like a description of timeout, and they hand that to the family, maybe they go over it a little bit, and that doesn't tend to stick. So what we know sticks more is much more involved type of exploration with parents about what it is their thoughts are about discipline strategies, what their thoughts are about timeout. Is this something that sounds like it's culturally consistent at all with what their family might do? And then helping them sort of formulate how they're going to approach discipline, maybe in a way that is more effective for that particular child with what they're presenting, which may be timeout, or it may be something that kind of is adapted and looks a little bit different, right? But it needs to be practiced. It needs to be developed. It can't just kind of be handed out to people. Handout stuff, unfortunately, doesn't work all that well, particularly when there's more complex problems. Parents need a huge amount of support to be able to make changes in some of their responses and be consistent, and to help the child self-regulate, or the teen self-regulate in the home. Okay, so you'll see this little, my little graphic here. I always have to have a graphic for things, like graphics. So we've got the classroom and based kind of learning and skill. We require a caseload. We added this somewhere along the development of this program because we realized that many people were being placed in settings where they would, it would seem, have the opportunity to have a caseload that's appropriate and to build skills, but it wasn't happening, right? So we needed to then provide a little bit more leverage for them to do this by actually saying, you need to have 2 cases with anxiety, 2 cases with depression, 2 cases with, where you've got primarily behavioral issues, where you're working with parents, and that we have to have really good placement settings that people are getting that supervision and getting support. And it's not necessary for the supervisor to know all the interventions that they're using, but it is super helpful for them to be somebody who's experienced, who gives them a lot of just the overall practice skills. Some of our students come in and they're really good at moving through placement up through their manuals and understanding how to kind of do teaching of different things, but maybe they're not so good with engagement. And that is super important. And we expect them to be able to learn a lot of that from their supervision. We then do reflection on practices and documentation of practices, which then moves into more classroom-based learning and more coordination with placements. So next slide. So the hands-on diversity in child mental health. This is the recent funding that we received from Polk and ACMHAI. This provides an opportunity to support diverse students who are committed to working in child and adolescent mental health, who otherwise would have probably some difficulty either in getting through their MSW program, or would have difficulty staying in child and adolescent mental health because of the level of loan debt that they already have and the additional loan that kind of obligations they would need to take on. And also just sometimes the need to work, right? We have a fair number of students who come in who need to work because they don't want to take on, an overwhelming amount of debt. So we've had a program that's traditionally about 90% female. We have pretty good diversity with Latinx students, with 30% students for Latina. And we have a high proportion of bilingual students, sometimes as much as 50%, but we have a lower proportion of Black students. And overall, our number of male students is also very low. So our hope is with this funding is that we're going to make it possible for people who are showing strong leadership and strong interest in entering mental health, who are committed to being in direct practice and also to helping shape more opportunities for more access to mental health services in underserved communities, mainly in Chicago, that they will, by getting this greater financial support and then guidance in their first year placement. So we get them on track. So they're really competitive for some of the best placements and trainings that they could get. And that they also will get mentoring by experienced leaders in child behavior and child and adolescent mental health. So we have so far one student admitted for the first year, and we've got 2 students for our second year. So we're very excited about getting this started. Next slide. So some of the program challenges, we've already talked about a lot of these, right? In this environment of so much difficulty and such staff shortage, it's obviously just dramatically affects our students' experiences. So placements have varied in the extent I noticed particularly last year, in that they can provide a range of cases for students. I think that a lot of agencies and settings are just in crisis mode, right? So our students kind of saying, well, I need another case that has, it's been more difficult this last year for them to be able to accommodate some of that. We've had more folks in some placements that have been dealing with sort of the critical crises, and we do provide support and help for students to know how to deal if you have somebody who's coming in immediately, after hospitalization, how to support that. But it is something where sometimes they're just overwhelmed and they find it very difficult to kind of manage all the different pieces that they're being confronted with. And over time, we've really been happy to see. It used to be 10 years ago, I remember calling up agencies and talking about the program and saying, no, this isn't really consistent with what we do here, right? Because they really were not feeling that they were on board with the evidence-informed type of approach. So that's really changed. I would say at this point, I have more folks reaching out and saying, oh, we're interested in being a part of this program. Can you tell us, what would be involved in terms of getting an intern placed here? But we still have some challenges. And still sometimes have, particularly with agency staff turnover. Sometimes we've got a wonderful situation with a wonderful supervisor, and then people either move up, because they're able to advance, which is wonderful, or we lose people, altogether at the agency. And that means that we're kind of building with, relationships with a new placement. So, and then some students also particularly struggle to use certain evidence-based models. Every year I've got a couple of people who I talk with, and they say to me, yes, I have a child with ADHD. I'm not sure what to do. It doesn't seem to be working. I say, what are you doing? They say, well, I'm doing we're doing like skills building, and we're playing, he really likes playing Unos. We're playing Uno. We're going to say, what are the parents reporting? Everything's, they're having problems at home still, and they're having problems at school. So I say, let's go back. And they've kind of forgotten some of that initial sort of planning they need to do with the families, that it needs to be more family-centered work, and that they need to be working primarily with parents to be able to support that 8-year-old, in the classroom and in the home. And of course, the pandemic, just all the stuff that, we've already talked about and that Amy's mentioned. Next slide. So I'll talk very briefly about the Behavioral Health Workforce Education Center. This is a joint initiative from the Department of Human Services and the Illinois Board of Higher Education, which has been supported by some legislation, which is great because it means that we've gotten a funding line for this and it's now funded. It seeks to address the workforce shortage in behavioral health care. And it's going to have a hub and spoke type of model. So we'll have academic institutions that are connected to the centers. There are going to be centers both at SIU, the Department of Medicine Psychiatry, which is the lead center hub, and then UIC will be the secondary hub. And it's going to focus on trying to increase both the number of behavioral health workforce sort of folks who are entering, and then also deal with issues related to retention and education needs, but I think also do help support keep people. If people feel competent, people feel like they know what, how to address family needs and child needs, they're more likely to be able to, feel that they can sort of stick it out through some of those initial difficulties with transitioning into the behavioral health workforce. So that will be our focus. And I think that UIC will, as I'll see in a minute, we've got some particularly interesting issues. Even though we're the secondary hub, I really think we've got some really interesting areas that we're going to be working on that are very consistent with some of the stuff that we've been talking about. Next slide. So UIC is going to oversee work in 4 different areas, increasing professional development opportunities, which means trainings and other types of support that might be helpful. This is going to be a model which we're really not using a top-down approach, is one thing to keep in mind. From my perspective, as someone who has really seen kind of the value of evidence-based interventions and think that these are really important to disseminate, I love to do trainings where people are supported and help kind of garner resources so that people can get more access to those trainings. But agencies are stressed right now. Agencies may not feel like they need to start requiring or have the capacity for their staff to participate in these types of trainings. So we're really going to be going to agencies and other institutions that employ the behavioral health workforce and asking them, what do you need? What is it that is going to be supportive to your workforce, and how can we help support that? What sort of resources can we bring to this that will help, support you? We also be focusing on the educational needs of currently uncredentialed community-based workforce. So this is very much consistent with what Amy was talking about, and increasing behavioral health within settings such as integrated care models. And this should be increasing behavioral health care in settings in integrated care models. So this is we've got a whole group at UIC that's real excited about working with primary care and nursing, pharmacy, and having those folks be able to better support behavioral health needs through the contacts that people are often more likely to have with primary care or other specialty settings than they do with behavioral health. And then parent support models for dissemination within the state, something we've been given. Yay. So this is very consistent with Amy's call for paraprofessional support or uncredentialed workforce, parent advocate, wherever we want to call them, for support for those workers and the development of a curriculum that will be able to be used, hopefully, and disseminated through different settings, whether there's through agency types of trainings or it's through a credentialing process where people are able to maybe get some extra credentials with, to have received particular types of more behavioral health oriented types of training. There are many possibilities for these initiatives. And again, priorities will be set through these advisory and work groups in each of the areas. Next slide. Okay, I've run out of time. I don't want to cut into somebody else's. So just to repeat that we will have provider groups, current providers, people with lived experience who are going to have a voice in all these decisions with a very collaborative approach. So I really look forward to, I hope, working with some of you in this work as we go forward. Thank you all very much. Next slide.
Thank you, Dr. Leathers. I just wanted to make one comment. So we have discovered recently that the Medicaid rates have actually been increased fairly nicely. But the one, individual therapy has been increased pretty significantly, for example. But the one rate that has not been increased is for family therapy, which is, you just heard Dr. Leathers talking, that's really the evidence-based modality for children's mental health. So it was if there's anything we can all do to help raise the issue and try to get that corrected, I think it would be fantastic. It seems to me that the family therapy practitioner should actually be paid more than the individual therapy folks are, because it's just much harder to do. I want to turn it over now to Michelle Turchi-Mims, who works with the Community Behavioral Healthcare Association, and the Illinois Children's Healthcare Foundation has just awarded them a grant to do another workforce development initiative. So Michelle, I'll turn it over to you.
Hey, good afternoon. Thank you so much for inviting me to present today. And I'm going to talk about, as Amy said, the new funded opportunity, ensuring and enhancing the clinical skills of the children's mental health workforce pilot. And who in the heck figured out that name? It's a mouthful, so we have to probably shorten it a little bit, but that is our project. Next. So the goal of the pilot is, by providing funding to support clinical supervision and intern stipends, there will be a positive impact to restore some of the community mental health centers and behavioral health clinics the capacity to be a source of training and professional development. As Amy noted, that was what happened in the past, and we're looking to be able to increase that capacity. Next. So there are 4 components to the project. One is to build supervisory capacity. The next is to build a workforce pipeline, increasing clinical competency and confidence, increasing access to children's mental health services. And I'll just briefly talk about these components. Next. The first is building supervisory capacity. So the project will be in 6 community mental health centers or behavioral health clinics across the state. We'll be funding a half-time LPHA supervisor to provide dedicated time to provide clinical supervision for 4 interns, as well as 2 licensed eligible clinicians each year. This is an opportunity to help rebuild some of that capacity, but it also will have the benefit of having community mental health centers and behavioral health clinics be seen as a resource for new clinicians seeking the required supervised experience, and hopefully have the added benefit of assisting in staff recruitment. Next. And building a workforce pipeline. As Dr. Leathers noted, there's a need to increase the diversity in the workforce. Paid internships are really the exception in mental health, and especially in children's mental health. There are even fewer grants supporting children's mental health since the disinvestment in mental health in 2009. So there will be 4 interns for each of the 6 sites, and they'll receive a $2,500 stipend each year to offset time spent in internship activity. And we understand that this is not fully covering the cost, but we look at it as it being a start to be able to provide some funding to offset some of the costs and hopefully be able to build a more diverse workforce. Next. Increasing clinician competency and confidence. As was noted in Amy's presentation, folks are just not feeling competent and confident to be able to provide those services, and we see that increases staff turnover. So with the goal of having increased exposure to training and supervision with evidence-informed practice, to have an increased focus on training and supervision. And with 4 interns per site, we're hoping that building a cohort of interns expands learning opportunities, that they'll be able to learn from each other, and that each of the 6 sites that will be part of the pilot will have the opportunity to learn from each other as well. Next. And also there's the goal of increasing access to children's mental health services. By virtue of adding 4 interns per agency per year at each of the 6 sites, there'll be increased clinical capacity with an anticipated additional 350 youth and families being served over the course of the pilot. Next. So our anticipated timeline is that the RFP will be released on May 12th. We'll have an informational call on May 18th. Applications will be due on June 10th. We'll be announcing on June 28th, and the program will start on July 1st, and it will be two years and commencing on June 30th of 2024. Next. Mine was short and sweet and gives us opportunities for any questions or next steps. Thank you.
Thank you.
Okay, well, I
Judy.
think we can open. I'm sorry, I was gonna say,
I was just going to say, maybe you want to stop sharing your screen so
yep, let me pull
people
this
look bigger than postage stamp.
up. All right, so if folks want to, since we have, I think we have a small enough group here that if you wanted to go ahead and ask a question.
There's a comment in the chat that I'll read. From Donna. Hi, I taught and was a program director for, I assume that's occupational therapy at Illinois Community College for 13 years. 2-year associate's degree curriculum is highly preparatory in foundations of mental health and pediatrics. These programs are already nationally certified and licensed. They would not have to be supervised by an OT. If license training as an add-on would be provided for RSA levels. Have folks considered this as a recruiting area for paraprofessionals? Perhaps additional training could be made possible to collaborate with state training. More OTs end up in the school system or nursing homes this time. Interesting. Has anybody, I had a meeting with an OT at one point, and it was like, it was a surprise to me about how really well versed they are in mental health. It was, but I don't know if that's been a common pipeline to get folks in.
Well, this is Donna, and I can't show my screen because I have very poor connection. Thank you for reading that. I have just recently retired from my practice, and yes, we are trained mental health professionals, and we could become QMHPs too, but there's limited settings. Basically, I have been enmeshed in mental health practice my entire life through pediatric, school-based, and so forth, and through teaching. But the issue is that, yeah, typically people think of OT as with PT located in hospital, rehab-based. I'm a mental health first aid instructor and so forth. You know, I just think there are a few of us out there, and I just think the OTA opportunities, again, when you're telling people work in the schools as far as competitive salaries, if it could be a little bit more competitive, they could do that. And I think some in the past, maybe some of the myth busting is that an OTR would be required to supervise them, but that would not be the case if they are not working as a OTA as such. They would have the skill training, and I just think it would be very close aligned. I did national certification accreditation levels twice during my tenure there, and I just feel like looking at the outline for the trainings, those folks, what a good group to possibly access.
Yeah, that is interesting. And I also would imagine, actually, this is more of a question, are OTs able to be licensed as a LCPC? Is that one of the disciplines? Donna, you're on mute.
Yeah, you're on mute, Donna. There you go.
Yeah, well, yeah, no, they are not. They would not be. It's a separate track of training. But again, an OTR, myself is now a master's level, actually turning into a doctorate level, but would be able to, again, be a qualified mental health professional with a year of training, but that's not the typical course anymore. I'm old enough to have where there was a good contingency, about 20–30% of practitioners did have that opportunity. I had opportunity training, but not quite a year. And so that's kind of where I've kind of said, so yeah, they would not be, but they're commensurate with MSW LCPC if they are qualified and meet that. But there are very few of them around.
Yeah, interesting. Are there examples that you guys are funding as part of the 708 network related to workforce, other workforce examples?
You know, not specifically, but I've started bringing in interns, psychology students from the university and working them through the mental health board. Again, we're not doing direct care, but again, if we could look at that, I think that definitely is a way to that we could play a part or play a role in that. In terms of working with the interns, it's been such a great experience for us in mentoring and bringing them along. Like I said, we're more administrative, so it's a little bit different. But I think that definitely would be something that we could certainly consider and look at through our own communities or counties that we serve and how we can be a part of that. I did want to comment and commend you, everyone here that presented, and the work that you've been doing. I know this has been going on for some time. These groups have been meeting, and just as you were sharing, I kept thinking, and what else I thought would be needed to support this. And then the next slide, you'd address that. So I think, you know, and I can only date myself way back when I ran a children's programs. I had a 16-bed facility, and all of the things you're hitting on, you know, the salary, we had such a high turnover, huge turnover. And it looked like all I was doing was training people so they could move to their next job. And so that training element is so critical, and giving them that competency and that skill along with the salary. And then the clinical supervision, I think, is such a relevant piece, and supporting them along the way. Just because they've had the training, they need that support. I work with Redeploy Illinois, and they manage some very, very difficult, and these are more juvenile justice involved kids, but some very difficult family and child situations that they're working with. And I mean, that's one of the things that has really been instrumental in helping those staff, retaining those staff, keeping those staff in place, is that clinical meeting supervision. And I mean, they have an ongoing scheduled supervision with their staff to support them all along the way. And it's really made the difference in the turnover and being able to work with very difficult families with mental health and other issues.
That's great, Debbie. We're doing an evaluation. We're funding an evaluation of the pilot that SEBA is doing to really get a sense of, can we help restore some of that training culture that really has been lost in the community mental health agencies. And is a foundation. So we fund all over the state of Illinois in the area of children's mental health and children's oral health. And we've been trying to be increasingly flexible in terms of the way funding is used. And so, for example, we have a number of fairly large system of care grants where we're really encouraging our grantees to use grant money to do things like hiring and retention bonuses, provide extra training for the staff that are at hand. Agencies just don't have the funding to do that. And, when I was thinking about talking to you guys, it occurred to me that the 708 boards often have sort of a level of flexibility about what is funded and supported through the grants that is broader and potentially, I think, more helpful than sometimes the state funding is, which is really very prescriptive and at this point in time really largely fee-for-service generated. So I was just curious if the 708 boards have moved towards that kind of flexibility in terms of funding.
One of the things, I'm out here in DeKalb County, and one of the things that we were able to do is we once again, same issues in professional development and training is a huge one. And so we partnered with our community mental health organization, and we brought in a PESI, PE is a PESI contract to provide training in CEUs to their staff, where we actually hold the contract and we can offer those trainings to any mental health board funded organization. So it's been like a 5-to-1 return on our investment. So for $10,000, we've gotten $50,000 worth of training. And, you know, kind of different feedback on how useful it is, but it's been very useful for new hires for those 30, 60, 90 days to be able to get these trainings kind of right off the bat. And so it's supplemental to what they're doing. So we're keeping an eye on that. It was a pilot. We ran it 1 year. We're looking at doing it for the second year to see if that's really worthwhile. And the other thing I found very valuable today is we're really 0 to 7 is an age group that we found out we're just kind of round robbing referrals, and nobody's actually offering services to that age group. And so we're looking, where can we make at least an entry to impact, and family support, peer support is something we're really, really looking at. So I'm excited to hear about the paraprofessional and look at ways that maybe we can be supportive of the work being done in that area. So thank you so much for this today, and really appreciate it.
That's great.
Any other questions or comments from the speakers? Or
No, I just want to say thank you to everybody who's kind of given us a little bit more to think about too. I really appreciate it. And I hope that we get a chance to work together in the future.
Yeah, the 0 to 7 age group is, you know, first of all, not a lot of mental health clinicians know what to do with children, and even far fewer know what to do with little kids. And those evidence-based interventions really are all family parenting based. And, you know, I think that's why the work at Jane Addams is really particularly exciting and important. And
Thank you.
maybe you could do a certificate for early childhood.
Right. Yeah, we talked
There you
about,
go.
we talked about that. For sure.
Next steps.
well, this has been great. We really appreciate you all joining us and speakers joining us today. So if there's follow-up questions, would it be okay if they reach through me, and Amy, I could come contact you or any of the other speakers for any follow-up questions? Like I said, we'll post it on our YouTube, and then we'll also share it with our members. So we might get some questions following that. But again, we truly thank you. It's been very informative. Appreciate it. And I think that's it.
Okay. Thanks, everybody.
You guys have a
Thank
nice
you.
afternoon. Thank you.